Hello, in this video we will go through how to read ECG strips in 5 short steps. This is the shorter version of the video that I previously put up via our ECG channel. So the method, we want to determine 5 things. These are rate, rhythm and conduction, access, hypertrophy and workload distribution, and then we mainly focus on the ventricles, and lastly signs of ischemia. Now first, rate. This can be determined in a number of different ways. What I prefer to do is to count the distance between QRX or R waves on the strip. This is because I prefer visual confirmation instead of doing calculus or additions. Now what I do is that I look at a strip like here in this top illustration, and I find an R wave where I start, and then I scan the trace and find, say, there's another R wave here. Then I count big boxes or blocks between these points, and I say 300, 150, 175. This means that this distance between our starting reference point, R wave here, and the R wave at this point, there will be 75 beats per minute with this distance. If the distance was shorter, say over here, it would have been 100 per minute. Now this is true for 25 millimeter second strips. There are 2 configurations of the speed of the EKG machine or ECG machine. These are 50 millimeter per second, which are used in some countries, and other Scandinavian countries use them. Here in Poland and the United States, it's pretty common to use 25 millimeter per second strips. The only difference in practice is that you have to, when doing, say, this counting method and looking at intervals, which we will do soon, you just have to double the distance because the strip is moving at twice the speed. Now, in case of irregular rate, which can happen, we do a little bit of math. We take the fastest rate and then we add this with the slowest rate and divide by 2, which will give us an average. And then the fastest rate will be the area where we have the shortest distance between 2 R waves, and the slowest rate will be the place where we have the biggest difference, longest distance between 2 R waves. Now we can look at this example. For instance, we count, we say 300, 150, 175. So on this ECG strip, it's a 75 beats per minute. Now in case of bradycardia, because you see this visual method of determining heart rate only goes to 50. So if we want to go below this, we locate these 3-second intervals, which are usually found on the upper rim of an EKG strip, and then we count them between 2 3-second marks, which gives us 6 seconds, and then we times it by 10. So if we count here, there's 1, 2, 3, 4, 5, 6, 7 QRSs within a 6-second period. Then we times this by 10, and we have a 60-second minute interval, and that means that we have 70 beats per minute. This can also be used just to determine normal rate, but I prefer to do it by observation if possible. Now, second thing we want to look at is rhythm and conduction, and by conduction we mean how the electrical current moves through the heart. Now we want to see if this is a sinus rhythm, or how this electrical conduction goes through the heart. Now what we mean by sinus rhythm is that it has this P before each QRS, meaning that atria contracts before the ventricles, and that is regular, and that we know that the origin of rhythm is in the sinus node up here. Now this we can see by narrow QRS complexes, because if we have, say an ectopic a rhythm originating somewhere else than the sinoatrial node, like say in the ventricles will contract dysynchronized and kind of not in order, so they will show up as broad QRS complexes. Now about the conduction, when we think about conduction, we want to look at two specific intervals that determine how the electricity travels through the cardiac tissue. Now the first one we look at is this PR interval. The PR interval tells us how long it takes for the electrical impulse to travel from the atria and through this pause it has in the AV node, allowing the ventricles to fill up with blood before systole. And then we also look at the QRS duration, which is essentially how long the ventricles, how long the electrical current moves through the ventricles. And this should usually be a quite rapid movement, synchronized with a narrow, slim complex. So PR or AV conduction time should be on a 25 millimeter per second strip, less than one big block. That would be around 120 to 200 milliseconds. Now 200 milliseconds is about one big block, so if you're around one big block, that's fine. Second thing was the QRS duration, or the ventricular ventricular conduction of electricity. This should be quick, less than one big block, 80 to 120 milliseconds. Now if we have problems with conduction, we mainly categorize these into problems of the PR interval conduction, or meaning the atrial to the ventricular conduction, the AV conduction, or the QRS or ventricular conduction. Now, so prolonged PR interval, this indicates that we have a problem with the conduction from the atria to the ventricles, classically called the AV block. Now, if we have a prolonged QRS complex, we have a problem of ventricular electrical conduction, which we can see in, say, bundle branch blocks. Now, these illustrations here on the right, the first one, the top one, is quite a significant pathology, but if we just focus on the QRS complex here, and here another one at the bottom, you see the first one has a normal conduction. It's narrow, less than half a big block. Now on the second one here, the below one here, we see that it's getting broader, and it's if you consider all the way from here, it's quite bigger than half a big block. So this is the lower illustration is bundle branch block. In order to determine if it's a left or right, which are the two subcategories of a bundle branch block, we have to look at what precordial leads are involved, but we will get to that soon. Now, these are all the different blocks that you can encounter. It looks kind of extensive, but to make it simple, we just divide them into two groups, supraventricular or ventricular, and the biggest distinguishing characteristic between these two is that in a supraventricular block we have a narrow QRS, less than one big block, because the arrhythmia, the problem of conduction, is above supra the ventricles. The ventricle conduction is not affected, and it's still narrow and looking normal. If we have a ventricular conduction problem or ventricular arrhythmia, the QRSs are broad because electricity doesn't flow through the ventricles as smooth and synchronized as they normally should. Okay, and I will probably make, we in Loop ECG will probably make another video later going into detail on arrhythmias, because it is important and very fascinating, but it can be a little bit extensive if we go into it. But just remember for now the difference between supraventricular and ventricular arrhythmias. Now, third point, axis. When we talk about axis, we're talking about the vertical conduction of electricity, the direction of it. Because normally we want it to be between -30 up here and +90. This is slightly to the lower left of the patient. This is because this is the direction the heart is oriented, and where we have the direction of the left ventricle, which is the biggest mass and muscular mass of the heart, and where the mean electrical direction goes. Now, how to determine this? The simplest method, just to quickly see if the heart is having a normal axis, is to look at lead 1 here and AVF here, marked by red lines. If both of these are positive, meaning that the sum of electrical activity and their QRS complexes are above this isoelectric line, we can say that we have the 2 thumbs up sign. And this means that we are almost guaranteed, or pretty much guaranteed, when we have 2 thumbs up sign, that the cardiac axis will be somewhere between -30 to +90, which is normal. Now, the second step, if you want, it's not necessarily required, but it is nice, your attending doctor will probably appreciate it, is that you can find an isoelectric QRS, like say 3 on a strip was isoelectric. This means that the cardiac axis would be 90 degrees to this. And by first doing the 2 thumbs up sign, we would know that the axis is somewhere in this area here, not up here. And then we would just draw a perpendicular line standing at 90 degrees to the third limb lead line here, and we would see the exact axis in degrees if we drew a circular degree circle above this. Okay, so fourth point, hypertrophy. This is hypertrophy is essentially just an adaptive process of the cardiac muscle to demand on the heart chamber. Now, normally we want to see a positive R-wave progression towards the left of the heart, looking at the precordial leads, V1 on the right side to V6 on the left. We would see that the R-wave is getting increasingly bigger and more dominant, the downward component of the QRS complex becoming smaller and smaller compared to the upwards component, as we move towards the left of the heart, where the left ventricle is located. So when we talk about ventricular hypertrophies, there are 2 types, right and left. Right ventricular hypertrophies are normally associated with pulmonary problems like COPD or asthma, or any sort of problem with the blood flow into the heart, into the lungs from the right side of the heart. Now, left ventricular hypertrophy can be for a number of reasons, but you can imagine anything that opposes blood exiting the heart, like some kind of aortic stenosis or systemic hypertension, anything that prevents blood from leaving or impedes blood leaving the left ventricle. Now, the criteria for this is to look at the precordial leads. For the right ventricular hypertrophy, we look at V1. We see a tall R wave, and as we move towards the left, towards V6 on the left side, we see that the R wave is becoming smaller and smaller, meaning that the dominant electrical activity and thereby dominant muscle mass is on the right side of the heart. Now, left ventricular hypertrophy, this is a bit more tricky because normally we have positive R wave progression towards the left, so this is a normal finding. but we have this arbitrary rule that we look at the S in V1 plus R in V5 on the left side must be 35 mm or more, or 7 big blocks in amplitude. Here we see examples of this. Right ventricular hypertrophy, it's quite easy to see. You see the R wave is becoming smaller and smaller as we move towards the left side of the heart here. Now, left ventricular hypertrophy, you see the R wave is getting bigger and bigger as you go towards the left on V6 here from V1, which is normal. But we can also see that V1 in the QRS complex in V1 is very negative. It's very deep, meaning that a lot of conduction is going towards the left side of the heart. Now, last point, ischemia. We have three things to look for here. This is the Q wave, which means that which indicates old infarcts. What we look for then is significant Qs, which are 1/3 depth of the height of the R wave. And also we want to find all these findings in 2 leads or more for them to be significant. A single finding or a finding in a single lead could be a misplacement of the lead or some other disturbance, like picking up breathing movements and so forth. Now, ST segment elevation or shift is very interesting, because we look at the ST segment when we talk about infarcts or heart attacks. Now, what we look for here is the J point, which is located here. This is the junction between the QRS and the T wave, or the isoelectric line here. So normally you see the J point, the QRS ending, would be at the isoelectric line, which is normal. In a ST segment shift, the J point here, this angle you see here with the mouse pointer, is shifted away from the isoelectric line. When it's elevated, it's moved up. When it's depressed, it's moved down. Now, the difference between STEMI, which is ST elevation, and non-STEMI, which is depression, is essentially the degree of thrombosis and infarction. ST segment elevation are usually considered more severe and need more aggressive, or both need aggressive treatment, but ST segment elevation is more severe than NSTEMI. T-wave inversion, as seen here, is simply ischemia. The cardiac tissue is insulted by lack of oxygen or blood supply, but is not dying, it's not infarcted. This can normally actually be seen in AVR leads, which are placed kind of opposite to the direction of the mean electrical direction or current direction, up on your right, up on the patient's right shoulder, which means that it kind of gives an error image of the electrical conduction. So if you see this in AVR, that's normal, but in any other lead, this indicates cardiac ischemia. So we also can actually see where the ischemia is located, which is both for diagnostic and treatment considerations quite important, and it will make your ECG reading more complete. Now, to determine this, we look at which leads show these ischemic or infarctic changes. If we have it in the precordial leads, we are talking about anterior ischemia, V1 or to V6. If we have it in the limb leads, especially inferior leads, 2, 3 and AVF, we are talking about inferior ischemia. Now, you can also, you probably heard about lateral ischemia. This is if we say we have changes in V6 or V1, which are respectively on each of their sides, V6 being on the left and V1 on the right, or in say leads 1 AVF on the far left or AVR on the far right. So that's just to keep in mind. Now, about ST segment elevation depression. Remember, J point here is what we look at. And just wait until you see movement of isoelectric line at this J point by one small block in at least 2 leads before we sound the alarm, because ST segment elevation are a medical emergency. Now, if you look at these 2 leads, which one do you think is the one that's showing ST segment elevation, or at least showing it the most? Now, that would be the right one, because if we look at the J point here, it's not so much shifted upwards, a little bit maybe, but not much. But here, the J point, which should be somewhere here, is shifted a whole big block up. So this is a significant finding, especially if we have this clinical picture of a patient in having a heart attack, like clenching their fist over their sternum, cold sweating, pressure sensation, chest painful, radiating down the left arm, and this on the ECG strip. You really want to get going with starting treatment, this MONA B protocol for infarcts. Now, to summarize quickly, we first determine rate just by visually counting big blocks between R waves, and remember, this is 1 big block between each 425 mm per second strip and 2 big blocks on 50 mm per second strip. Secondly, we'll look at rhythm and electrical conduction in the heart. Rhythm, just to determine if there's a P before each QRS and it's regular, then it's a sinus rhythm. For conduction, we look at the intervals, PR interval being 120 to 200 milliseconds or less than 1 big block. In case this is prolonged, we are considering AV blocks. QRS interval should be 80 to 120 milliseconds, or normally less than 1 big block. If this is prolonged, we are worried about bundle branch blocks, left or right. Now, 1 big block is 200 milliseconds on 25 mm second strips. On 50 mm per second strips, we double this, so then 2 big blocks is 200 milliseconds. Thirdly, we look at axis, determining if we have 2 thumbs up sign, meaning positive limb leads 1 and AVF. And to accurately find the axis, we find the most isoelectric QRS in a limb lead. Axis will be perpendicular to this. Fourth, we look at hypertrophy and workload distribution. Normal R-wave progression as we move from the right in V1 to the left in V6. Also, we should have more dominant R-wave in V6 than in V1. And to determine the location of the interventricular septum, which may be shifted left or right if we have hypertrophy in the corresponding chamber, we should also look at isoelectric QRS, or try to find it in either V3 or V4. Lastly, we look for ischemia with findings in 2 or more leads. Firstly, we look for old signs of old infarcts. This can also be found in the patient history, of course, but if we just want to do it on the ECG, we look for Q waves, which are 1/3 of the R wave. Secondly, ischemia, shown by inverted T waves, and please disregard AVR, because remember its position on over the patient's right shoulder makes it a mirror image of the heart. And lastly, we look for ST segment elevation by 1 small block or more, or depression. And please note that it is the J point, this angle between the QRS and the isoelectric line or T wave, that we look for. So that was it for this video. Thanks for watching, and I'm sure in not too long the next video will probably be on cardiac arrhythmias. So take care.